Welcome back to the deep dive. Today we are opening up chapter 48, and this one tackles a really core system, doesn't it? The musculoskeletal system.
Absolutely. It's, fundamental. We're talking over 200 bones in adults, plus all the joints, ligaments, tendons.
Yeah.
It's this intricate web.
Yeah, constantly trying to balance like movement and stability. It seems incredibly vulnerable when you think about it.
It really is. Dynamic, yes, but fragile too. So our goal today for you listening is really to give you a rapid, kind of high-yield overview of the key pathophysiology in this chapter.
Okay.
We're focusing on how things like trauma, infection, ischemia, that's lack of blood flow and neoplasms or tumors, disrupt that whole system. The aim is maximum understanding, maximum retention for your studies. We're sticking close to the chapter's structure here.
Got it. Okay, let's unpack the first big area, which is probably the most common, injury and trauma. The source material kicks off with some, frankly, sobering stats about who gets hurt.
Yeah, the numbers tell a story. Unintentional falls. They're the top cause of non-fatal injury for pretty much everyone.
Right.
But while kids fall all the time, the consequences change dramatically with age. For older adults, get this, 95% of hip fractures come from falls.
Wow, 95%.
And the mortality rate after that fracture, it's shockingly high. We're talking 18% to 33% within the first year.
That's huge.
It makes it a major public health issue, not just an individual injury.
Definitely. Okay, so before we jump into like broken bones, let's quickly clarify some soft tissue stuff. What's the actual difference, pathologically speaking, between a simple bruise, a contusion, and a real hematoma?
Good question. Both usually happen from direct trauma, and the skin stays intact. A contusion is, more minor damage underneath. You get that ecchymosis. The bruising color changes as the blood gets reabsorbed.
Okay.
A hematoma, though, that's a significantly larger collection of blood. Real hemorrhage, localized, it can get big enough to actually press on nerve endings, causing quite a bit of pain.
So the pressure is the key difference.
Exactly. And sometimes that pressure is so bad, the hematoma might need to be aspirated, drained, to stop more damage.
And what if the skin is broken? Say, a cut, a laceration, or even a puncture wound?
Then the big worry shifts to contamination, infection. Specifically, anaerobic infections, the ones that thrive without oxygen.
Like tetanus.
Tetanus, gas gangrene,
Yeah.
nasty stuff.
That's why even a small puncture wound needs careful management. You've got to prevent those potentially life-threatening infections.
Right. Okay, moving deeper into the joint itself. People always mix up strains and sprains.
Yeah.
Let's clarify.
Yeah, common confusion. A strain is typically an overuse thing, an injury to the muscle itself or where it connects to the tendon, the musculotendinous unit. Think lower back pain from lifting or neck strain, mechanical overloading.
Okay, muscle or tendon.
Right. A sprain, that's generally more serious because it involves the ligaments. Those are the tough bands connecting bone to bone. With a sprain, the pain and swelling tend to hang around much longer.
And the book describes those 4 grades of sprains, right? It really shows the severity. Like grade 3 is a complete tear of a ligament.
Yeah.
Exactly. Grade 4 even involves pulling a chip of bone off with the ligament and avulsion. But even after it's repaired, maybe surgically, there's a key point about healing.
What's that?
Well, fibroblasts come in and lay down collagen to repair it, but that new tissue isn't strong right away. It takes about 2 months, maybe more, for it to get enough tensile strength to handle strong pulls.
2 months. Okay.
So if you stress it too early, the ligament can actually heal in a stretched out, lengthened position.
Right.
And that means permanent joint instability.
That makes sense. You see that stability trade-off in joints, like the shoulder, right?
Yeah.
Which you mentioned is the most common place for a full dislocation.
Absolutely. The shoulder's built for incredible mobility, but the price is stability. So complete displacement dislocation, or even partial displacement subluxation, happens a lot there.
And the rotator cuff around it.
Right, those 4 muscles stabilizing it. You don't need to memorize all 4 names right now, maybe, but the supraspinatus is often the one that gets injured. And injury risk goes way up with age, often due to wear and tear, little microtraumas building up from impingement under the acromion bone.
Okay, let's pivot to the knee. Another joint under a lot of stress. What about meniscus tears? What's the long-term issue there?
The menisci are those C-shaped cartilage pads. They spread the load, absorb shock. Tears often happen with twisting injuries, like in sports.
Right.
The big deal, pathologically, is that if you lose that meniscus function, the joint surfaces don't line up right anymore. It messes up the load distribution. And that leads, almost inevitably, to progressive damage. basically setting you up for severe osteoarthritis later on.
So it's not just the acute injury, it's the long-term consequence.
Precisely. It's like a ticking clock for joint health.
We also hear about chondromalacia in the knee, especially under the kneecap, the patella. What's that?
Yeah, chondromalacia patellae, that's a softening, a degeneration of the articular cartilage, the smooth stuff on the joint surface, often right on the underside of the kneecap.
And why does it hurt?
It hurts when that roughened cartilage on the patella grinds against the femur. That's why people often feel it going upstairs, or after sitting with their knees bent for a long time, you're forcing those surfaces together. It's mechanical irritation.
Oh, got it. Okay, lastly for this section, the hip. We talked about fractures from falls, but you mentioned dislocations. What makes a hip dislocation such an emergency?
It comes down to the blood supply. It's critical. There are these specific arteries, the retinacular arteries, that run up along the neck of the femur. They're the main source of blood for the femoral head, the ball part of the joint.
Okay.
A bad dislocation, or even worse, certain types of hip fractures right at the femoral neck can stretch, kink, or tear those arteries.
Oh, cutting off the blood.
Exactly. If that hip isn't put back into place immediately, you risk a vascular necrosis, or AVN. The bone tissue in the femoral head literally dies because it loses its blood supply.
Okay, that's a perfect lead-in to our next section, fractures, how they heal, and those really dangerous complications like AVN. So classifying fractures beyond the cause, like a sudden injury versus stress fracture. What are the main types we need to know?
I think the most critical distinction clinically is open versus closed. Open, sometimes called compound, means the bone broke through the skin, huge infection risk. Closed means the skin's intact.
Right. Makes sense.
Then you have partial versus complete, like a greenstick fracture, common in kids because their bones are bendier, doesn't break all the way through, versus a complete break. And then severity, like comminuted, where the bone's in multiple fragments, more than two pieces.
Okay. So clinically, you see pain, swelling, maybe obvious deformity. The goals for treatment seem straightforward: reduce it, immobilize it, get function back.
Yep. Reduction means lining the bones back up either manually or surgically. Immobilization, using casts, splints, sometimes traction or internal fixation like plates and screws. But the healing, that's where the biology gets really intricate.
Tell us about that. What's actually happening in the bone?
It's fascinating, really. It happens in 4 overlapping stages. First is hematoma formation. When the bone breaks, blood vessels tear, bleed, and form a clot right at the fracture site. This clot forms a sort of meshwork, a scaffold.
Okay, the scaffold. Then what?
Then the inflammatory phase. The body sends in cleanup crews and builders. New blood vessels start growing into the clot neovascularization. Immune cells clear debris. And importantly, osteoblasts, the bone-building cells, arrive and start laying down the foundations of new bone. This starts forming the callus.
The callus. That's like the bridge.
Sort of. It starts soft, fibrocartilaginous. That leads into the reparative phase. Here, that soft callus gradually gets replaced by woven, spongy bone. It becomes much more rigid, bridging the gap. This is when the fracture starts to feel stable.
And the final step.
Remodeling. This takes the longest, months to years even. Osteoclasts, the bone-resorbing cells, come in and carve away the excess callus and any dead bone fragments. Then osteoblasts replace the woven bone with stronger, more organized lamellar bone, compact bone. The bone reshapes itself based on the stresses put on it.
Wow. It's quite a process, and if that gets disrupted...
That's when you run into problems like delayed union, non-union, where it just doesn't heal, or malunion, where it heals crooked.
Okay, now, this is really crucial, clinically and for exams. What are those severe early complications after a fracture that can be life-threatening?
Right. Beyond infection or bleeding, there are 2 we absolutely have to flag as emergencies. First, Compartment Syndrome.
Okay, what is that exactly?
Think of muscles being grouped into compartments, wrapped in tough connective tissue called fascia. If you get significant swelling or bleeding inside one of those compartments after a fracture, the pressure builds up because the fascia doesn't stretch easily.
So the pressure crushes things inside.
Exactly. It crushes blood vessels, nerves. It compromises circulation within that compartment, leading to ischemia, muscle, and nerve damage, potentially permanent loss of function if not treated quickly.
And what's the really dangerous pitfall in diagnosing it?
The absolute key symptom is severe pain that seems way out of proportion to the injury itself. Pain that doesn't get better with meds, pain on passive stretching of the muscles in that compartment. But here's the trap. You might check the pulse further down the limb, like at the wrist or ankle.
Yeah.
And it might be perfectly normal. That's because the major arteries often run outside these compartments. So relying on a normal pulse can give you false reassurance while the tissue inside is dying.
Oh, wow. That's critical to know. Treatment is surgery, right? Fasciotomy?
Often, yes, cutting the fascia open to relieve the pressure urgently. Okay, the second big systemic threat is fat embolism syndrome, FES.
Right, fat droplets getting into the bloodstream.
Yes, typically after fractures of long bones like the femur or the pelvis. These fat globules travel through the circulation and can lodge in the lungs, brain, skin.
What does that look like clinically?
It's life-threatening. Symptoms usually pop up 12 to 72 hours after the injury. You look for a triad: respiratory failure, difficulty breathing, low oxygen levels, cerebral dysfunction, confusion, changes in consciousness, and often a very characteristic petechial rash. Tiny little red or purple spots, often on the chest, armpits, neck.
That rash sounds like a key sign.
It is if you see it. FES needs immediate recognition and supportive care, mainly respiratory support.
Okay, really important complications. Let's shift gears now to problems within the bone itself, starting with infection. Osteomyelitis.
Right. Osteomyelitis infection of the bone and bone marrow. It's notoriously difficult to treat. Why? Because bone is rigid and antibiotics don't penetrate into bone tissue very well.
How does the infection usually get there?
It can be direct, like from an open fracture or surgery. That's actually the most common way now. Or it can spread through the bloodstream from an infection elsewhere that's hematogenous osteomyelitis. Right. Or less commonly, spread from adjacent soft tissue infections, especially in people with poor circulation, like diabetics with foot ulcers.
And the usual bacterial culprit.
Staphylococcus aureus is the big one, most common cause.
Okay. In chronic cases, the book talks about the body trying to wall off the infection. There are two key terms there.
Ah, yes, sequestrum and involucrum. You see these typically in chronic osteomyelitis. The sequestrum is a piece of dead, infected bone that has become separated from the surrounding living bone. It's like a foreign body harboring bacteria.
So the body can't clear it out easily?
Exactly. And the involucrum is the body's attempt to deal with it. It's a layer or sheath of new bone that forms around the sequestrum, trying to wall it off. But this often just traps the infection.
Making it even harder to treat.
Precisely. These features are hallmarks of chronic osteomyelitis and why surgery is often needed to remove the dead bone.
We should also quickly mention tuberculosis. It can infect bone, too. Pot disease.
Yes, pot disease is TB of the spine, tuberculous spondylitis. It spreads usually from the lungs or lymph nodes through the bloodstream. TB in bone tends to be very destructive, causing a lot of necrosis. The spine is the most common site.
Okay, now let's contrast infection with ischemia again. Osteonecrosis, or avascular necrosis, AVN, we touched on it with the hip. Remind us of the key point.
The key is bone death due to interrupted blood supply, but crucially without infection. That's the distinction from osteomyelitis.
And the causes are varied.
Very varied. Can be mechanical disruption, like we discussed with hip fractures or dislocations. Can be thrombosis or embolism, clogging the vessels. You see this in sickle cell disease or decompression sickness, the BENS,
Yeah.
vessel injury itself. Or very commonly, non-traumatically, it can be linked to long-term steroid use or excessive alcohol intake, or sometimes it's just idiopathic. We don't know the cause.
And the impact.
Well, as we said, areas with poor backup circulation like the femoral head are most vulnerable. The bone tissue dies. It leads to chronic pain, eventually collapse of the bone structure, and usually severe, rapidly progressing osteoarthritis in the affected joint.
Grim picture. Okay, let's wrap up our tour of Chapter 48 with the last category, neoplasms or bone tumors. What are the general red flags that might suggest a tumor, especially a malignant one?
The main things are pain, sometimes finding a palpable mass, and maybe impaired function or even a fracture that happens with minimal trauma, a pathologic fracture.
And the pain character is important.
Very important. Benign tumors tend to grow slowly. They're usually well-defined on imaging. Malignant tumors grow rapidly, look more aggressive, have fuzzy borders. But the pain from malignant tumors often has a distinct quality. It tends to be worse at night and doesn't get better with rest. That night pain is a classic warning sign.
Okay, let's briefly hit the big three primary malignant bone tumors mentioned, starting with the most common one, osteosarcoma.
Right, osteosarcoma. Most common primary malignant bone tumor. It's known for being aggressive. Peak incidence is in adolescents and young adults, often near the areas of fastest bone growth, like around the knee, distal femur, or proximal tibia.
And pathologically?
It goes quickly, often forms a sort of ball-like mass that breaks out of the bone into surrounding soft tissues. And unfortunately, it has a high tendency to metastasize early, most commonly to the lungs.
Okay, aggressive. Next, Ewing sarcoma, different type.
Different cell type, yes. It's a small, round cell tumor. Affects a similar young age group as osteosarcoma, but often arises in the shaft, the diaphysis, of long bones or in flat bones like the pelvis. The key diagnostic clue often is a specific genetic marker, a translocation between chromosomes 11 and 22.
Got it. And the third one, chondrosarcoma, hits a different age group.
Yes.
Well,
Chondrosarcoma is a malignant tumor arising from cartilage cells. This one is the most common primary bone sarcoma in adults, usually middle-aged or older.
how does it behave?
It's generally slower growing than osteosarcoma, but here's the catch. It's often resistant to chemotherapy and radiation. So the main treatment relies on wide surgical removal, sometimes quite radical surgery.
Okay. And it's crucial to remember, as the chapter points out, that these primary bone cancers, while serious, are actually much rarer than secondary bone cancer, right? Metastatic disease.
Oh, absolutely. By far, metastases to the bone from cancers elsewhere are way more common.
Which cancers most often spread to bone?
The big ones are prostate, breast, lung, kidney, and thyroid cancers. Those are the primaries you think of that frequently metastasize to bone.
And the symptoms are similar: pain, fracture risk.
Yes, pain is usually the major symptom, again, often worse at night. And the metastatic deposits weaken the bone, putting the patient at high risk for pathologic fractures, which can be devastating.
Whew, okay, that covers a lot of ground. This deep dive really drove home the sheer range of things that can go wrong in the musculoskeletal system, from, a simple bruise all the way to these incredibly complex and dangerous situations like compartment syndrome, fat embolism, or these aggressive cancers.
It really does. And if you wanted one final thought to tie some of this together, think about the body's limitations that this chapter reveals. Why are things like chronic osteomyelitis or vascular necrosis so hard to fix?
Yeah, why?
At its core, it often comes down to the nature of bone itself. It's rigid, and in many critical areas, the blood supply isn't that robust or easily rerouted. So when infection gets deep inside or the blood supply gets cut off, the bone struggles mightily to mount an effective defense or repair process compared to, say, soft tissue. It highlights how the tissue's own characteristics can turn an acute problem into a chronic, destructive nightmare.
That's a really powerful insight. The system's strengths are also, in a way, its weaknesses when things go wrong.
Exactly.
Well, thank you for walking us through that complex chapter, and thank you for joining us on this deep dive into musculoskeletal pathophysiology. Keep up the great work with your studies, and we'll catch you on the next one.